Welcome everyone to our session today. I wanted to go ahead and thank you all for being part of our presentation. And we are thrilled to have you here today for our ethics session. And we're going to talk today about advanced directives, myths, facts, and ethical challenges. And we have a couple of just housekeeping activities. We wanted to go ahead and let you know there will be a Q&A session, and we hope to get your questions in the Q&A section of the link that you have available to you now, or the screen that you have available to you now. And then we also have a chat box, and if you're having any technical difficulties, please go ahead and use that for any questions about technical issues. So what I'd like to do now is go ahead and begin. I am going to begin with our advanced directives session. So the title is Myths, Facts, and Ethical Challenges. And my name is Cari Levy. I am trained in internal medicine. I work as a palliative care physician and a geriatrician at the University of Colorado, and then also at the VA as the palliative care section chief. I'm very excited to have a lovely group of colleagues presenting today, and we're going to take you all through advanced care planning myths, facts, and ethical challenges. We have a really unique time right now to be talking about this, given what's happening in our world, and it does present a wonderful opportunity for us to have these conversations and think about what it is that we want. And so we will also then have a discussion about what can you do now, so some very practical suggestions about what can be done today. So our speakers come from a variety of clinical backgrounds and perspectives. Each of our speakers will introduce themselves so that you can connect the presentation and the material to that speaker. And then as you're asking questions and putting those in the Q&A box, you can direct them directly to an individual speaker or to the whole group if that's more appropriate. And then, as I mentioned, we will have a Q&A session at the end, and we look forward to your input at that time. So I wanted to go ahead and set the stage for what we're going to be talking about, just so we're all thinking along the same lines. So what is advanced care planning? Advanced care planning is a process. It's an ongoing conversation that you have with loved ones. And the idea is that we're going to provide direction to those who need to help make decisions when we're unable to make those healthcare choices on our own. The way we often do that is through an advance directive. So those directives are legal documents that tell your healthcare team what your wishes are, what you do and do not want for your healthcare. And again, these are active when you're not able to make decisions on your own. And then we'll go ahead and move to the next slide. And I do see that someone has asked about the slides and the materials, and we will have a PDF sent out with links to documents that we think you might find helpful. And then we'll also have a recording of this presentation. So you will have all the documents that we talk about today. So I wanted to go ahead and begin with a case, since this is often how we think about healthcare and what makes us think about what might happen to our family and perhaps to ourselves. So this is Mr. Cooper. Mr. Cooper is a gentleman we cared for several weeks ago. Of course, his name was not Mr. Cooper, but we've changed it for the purposes of today's presentation. A 72-year-old male. He was admitted to the hospital with shortness of breath, and the suspicion was that he did indeed have coronavirus. He'd been exposed to someone with coronavirus and was exhibiting characteristic symptoms. So he came into the hospital. The medical team was very concerned about the possibility of his condition worsening, and they asked him if he would want artificial ventilation, which would require a breathing machine, if his condition worsened. Because no visitors are allowed in the hospital right now, his wife was asked to leave. She had been in the parking lot while he was being seen in the emergency room, and so she had headed home. She did not have a cell phone, and the team was unable to reach her. He was not thinking clearly. He was very ill, And although he was able to communicate that he did not want to be on machines, he was not articulating his preferences in a way that made the medical team believe he had capacity for that decision. And so we were eager to talk to his wife. She was listed as next of kin on his medical chart. We did not have any legal documents to tell us who we should see to, and we did not have any prior advance directives to tell us what his preferences would be. It was about this time that we got a call from his daughter, who was out of state and understood that he had been admitted to the hospital. And she indicated that he would want to be on mechanical ventilation. She said, yes, I know he said in the past that he would not want to be on a breathing machine. That was if it were forever. This isn't forever. We've had friends who've had coronavirus. They go on a breathing machine, they go off a breathing machine, and they recover. And if he were able to speak clearly to you, he would be able to tell you that that is his preference. We felt very uncomfortable with this because he was telling us he never wanted to be on machines. And this is where we were as he was admitted and as he was clinically declining. So with that background, I want to go ahead and begin our presentations from the speakers who are with us today. The first will be Jean Abbott, who we have the great privilege of working with today. And so Jean, I'll go ahead and turn it over to you.
Thank you so much, Cari. That's Mr. Cooper is quite an interesting challenge. You put in all the curveballs, and we'll see if we can grapple with this. So my name is Jean Abbott. I work for the Center for Bioethics and Humanities at CU Anschutz, and I welcome you from the center. I am a retired emergency medicine doc and now work mostly with palliative care and end-of-life discussions in the community, and with a master's program we have through the CU Center for Bioethics. So next slide. So I'm going to start actually with some facts and history rather than the myths to get us all on the same page. Medical decisions have become much more complex over the last couple of decades, and they need to involve, and people wish to be more involved in making those decisions with their providers. In fact, in response to some very challenging cases that you may know about from history, the Patient Self-Determination Act was passed in 1991 federally, and it basically says that people have a right to decline even life-sustaining treatment if that is their wish and if they can make decisions for themselves. And so we've entered an era of what we call shared decision-making, which is where providers and patients and their families come together and they synthesize the biological and medical knowledge as well as the values of the patients in terms of making decisions. And new technologies keep pushing the need for this shared decision making as these decisions become more complex, as the burdens, the costs, the side effects of technology can become pretty darn steep. And different people come down on different sides of the question of what makes a life worth living. Or sometimes it's phrased as, what would you be willing to trade for some more time on Earth? And when you ask that, about 5 or 10% of people passionately believe that every day on Earth is sacred, even if you're in the ICU on the ventilator. But a lot of people have tipped more into a stance that says, you know what, quality is more important than quantity. And what each of us believes is a life worth living is pretty individual. So next slide, Jen. So here are some facts that help us. In surveys, 85–90% of people say, you know what, I would like to die quickly. I would like to die in my sleep. I would like it to be abrupt. And actually, about 100 years ago, that was the case. 90% of people died of infections or trauma or childbirth even. But nowadays, 90% of people have a longer trajectory, and only 10% of us have in this upper left corner is a swift death. Other people die with a trajectory that like the other types of graphs here. About 30% of people die with this terminal illness trajectory that happens with terminal cancer. Not cancer itself, but terminal cancer. And that trajectory is about 6 months, and that's the basis for the hospice benefit that Medicare provides. Another 30% die as an organ fails. They tend to get sick, they get better, they never get quite as well as they were before, but they have heart failure or liver or kidney failure or chronic lung disease, and they have a trajectory that's generally downward with some rescues, and the healthcare system can oftentimes bring them back until the time when the healthcare system can no longer intervene. And another 30% of people die of frailty, dementia, over sometimes a 5 to 10 year trajectory of just slowly getting worse. One of the facts that I like to remind people is that over half of us will not be able to make decisions for ourselves near the end of our life. And most often, we end our lives with some kind of an active decision. I'm not going to take the 3rd round of chemotherapy, or I don't want to go to the hospital this time, or I'm not going to have that Hail Mary surgery. I want to stay comfortable, or I want to stay at home. Or I don't want CPR when my heart stops. Next. So, what are some myths that I'm going to start with, and then some of my compatriots here are going to point them out too. The first one is, my family knows what I want. Don't worry about this kind of advanced care planning. They'll just do the right thing. And frankly, that has been shown in many studies to not be the case. People do not know what you want if you don't talk to them. In fact, doctors don't know what is best for you. For those of you who've read Being Mortal by Atul Gawande, doctors tend to think that safety and survival are the most important things. And so they want to keep people safe. They want to give them pureed foods and keep them in bed so they don't fall out and break a hip. And they also consider success to be survival. It's very hard to judge what would be a good quality of life for them. And without input from the patient or the family, that tends to be the priorities of many of us who are providers in the healthcare system. Another myth that I hear is, don't worry about this, I'm young, there's plenty of time to do this. And then when I'm talking to my students, I say, so, do you mountain bike? Do you ever bounce off your bike and land on your head on a rock? Have you ever skied into a ski well, or are you going to bounce your head off against a tree trunk? Even when you're young, there are instances where you're not going to be able to decide for yourself, and you need to think about somebody who can do that and what's important. So the other side, flip side of that is, don't worry, I'm young, I know exactly now what I want. I don't want CPR, I don't want to be intubated. And my goodness, that makes us smile as providers as much as the don't worry about it, I don't need to think about it, because it is interesting how we change and evolve over time. Next. So, what are the ethical dilemmas in terms of advanced directives? These written documents have been an invaluable step forward since the Patient Self-Determination Act, and they allow people to put down in writing what's important to them. But they have provided some interesting ethics consults for some of us and some challenges as we try to provide what we call goal concordant treatment for patients. First thing is that we adapt in ways that may well surprise us and those around us. 20 years ago, I loved to climb 14ers in Colorado. I think lots of people came to Colorado to do that. And I don't do that anymore, but I sure as heck love to hike the trails with my dogs, even if I'm not going to be climbing any more 14ers. In addition, as people, we aren't very good at predicting the future. Um, we don't know what we're going to want, and actually what we want changes over time. And if we document wishes that come in the standard advanced directives forms, that we either check that we do or don't want CPR or intubation, that's without context. It's in the abstract, and it's hard to extrapolate it to say, well, I would or wouldn't want dialysis or transfusions or surgery. What surgery? Maybe it would be to relieve symptoms. So writing things out can be a challenge as we sit down in the intensive care unit or the emergency department and say, okay, in this situation, what do you think your loved one would want? And in addition, as I sit in the ICU with families, something that got written about 5 years ago may not be the same as what's in our loved one's best interest now. In fact, in the ICU, we sometimes see somebody who came in 3 weeks ago and said, I want a full court press, I want everything, every attempt to survive. And we gather 3 weeks later, patient can't give us input right now, and the family says, well, she said she wanted everything, and right now things are in a very different place. Somebody may have sepsis, they may have 5 drugs that are keeping their blood pressure up, they're on the ventilator, and so written advanced directives can be a boon, but they can also be a challenge for us. Next. So why are we talking about this in a time of COVID? This is a time when it's amazing how many people are interested in talking about this. It's a very real context. It's a context where many of us, some of us who are older, think, yikes, there is an actual chance that I will die of an infection from COVID-19. And in fact, for many people, it may be a different kind of serious illness or death than they would have thought about. So somebody has heart failure and they figure that that's going to be their mode of exit. But wait a minute, this is a death that would happen with respiratory failure on a ventilator, in the ICU, in isolation because of the infectiousness of the disease. But luckily, I think we're all talking about it. We're seeing essays in the newspaper, and people have very different ways that they've come down on something like this. I have heard people say, you know what, I've had a great life. I just want to be comfortable and I want to stay where I am. Other people might say, you know something, I'm going to go for a Boris Johnson. I'm going to go into the hospital, I'm going to get oxygen, and maybe I'll need to be intubated or not, but let's give it a try. There are a couple of people who are in the midst of cancer treatment, and we have heard from them, wait a minute, my cancer doctor says that I have a couple of years to live, and I'd like to give that a try. So I'm going to suspend the DNR that I had in place because I have cancer. So all sorts of different thoughts happen. Wait a minute, I've got a granddaughter who's going to have my first great-grandkid in a month. I want to try for seeing that great-grandkid. Next. Here are some of the statistics, and the statistics are changing. We have to remember when we're giving this talk, because I don't know about you, but the sands have been shifting and the statistics have been shifting. But we do know that the greatest number of deaths are occurring in the older age group. And that too is part of the calculus that is changing for people as they think about what a death would look like with COVID-19. Next. So what do you need to know? And then I'm going to give this off to my wonderful colleagues. The most important advanced directive, I think we all on this panel will agree, is determining the agent who would speak to you in a document that we call the Medical Durable Power of Attorney. It's available from the state. We're going to put it in with the resources for this talk. But who is it that you would like to speak for you if you can't speak for yourself? In Colorado, there is no slam dunk automatic hierarchy of who will speak for you. And if you don't decide who will speak for you, then all the people who care about you, your family members, close friends, have an equal say around the table where they need to decide who knows you best, who can best speak for your values. A reminder that written advance directives need to be updated because your wishes are going to evolve. And most importantly, the documents are not enough. They're a good start. They help you start to think about the kinds of questions that you need to consider. But conversations are the key. Sitting down with the person who's your agent and with the other people in your life who are going to support that agent. What matters to you most? What are your values? What are you willing to trade for some more time? What is worse than death? And so you need to have those conversations with those who support you and who will also need support as they're navigating the arc of the end of your life. So now I'm going to turn it over to Peggy here. Go ahead, Peggy, and introduce yourself. You're on mute.
I was hoping that wouldn't happen. Hi, I'm Peggy Budai, and I am a clinical nurse specialist and nurse practitioner. And I work within UC Health's older adult and palliative care team here in the northern region in Colorado. And I also worked as an in-house nurse practitioner for a skilled nursing facility here in Fort Collins, and really saw every day the benefits of advance directives, especially when families had had good discussions about what their preferences were. And one of the things I tell people, it really is a gift to give your family to get your advance directives done and to have these conversations. So one of the things I wanted to talk about is some additional myths in addition to the ones that Jean pointed out. And it's a common misconception or myth that if you have a living will that says you don't want life-sustaining treatments, that that's all you need to do. And this can give people a false sense of security. People may forget when they enact a living will that it only comes into effect when someone has been determined by two qualified physicians that they have a persistent vegetative state or coma or are in a terminal condition. And because of this, really living wills don't cover many of the end-of-life scenarios that may occur. Actually, in common practice, living wills are often used really to spark conversations with healthcare agents when there is a crisis. So if you're seriously ill or do have advanced frailty, you may want to talk with your provider about completing a MOST form rather than just a living will. MOST form stands for Medical Orders for Scope of Treatment. So to simplify, or in other words, if you or a loved one knows for sure that you would not want attempts at CPR like right now today, it's best to have stated this on a MOST form. And again, to reiterate, they're meant for people who are chronically ill or who are experiencing frequent hospitalizations. They're really not for everyone, not for most healthy people. And there isn't time to go into all the details about the MOST form, but we'll send out resources when we send out the information, we'll send out additional resources for those of you that might have questions about that. Also, the next myth is many of you may have completed advance directives with a lawyer, and these documents are in a file cabinet or a safe deposit box for safekeeping. And in order for these documents to really be useful, they have to be readily available. So we recommend people do have a hard copy in their home that's easily findable, even putting it on the side of the fridge, and that people take pictures of their documents and have them on their phone. That can be a nice, really easily accessible place to have them. The other thing is it's important to ensure that they get into the healthcare record, and medical records departments at your provider or the hospital can help with that. The other myth is when people go to the hospital and they have a conversation with their doctor about their preference, oftentimes people think that this might need to be all they need to do. But if this wasn't documented in an advance directive, then the next time it will be hard to know. It'll be another conversation. So just reiterating how important it is once you've had a conversation, picked who your agent is, to take that extra step and fill out the medical durable power of attorney form. And then again, get it on your phone. And then the last myth is, finally, if you don't have a family or best friend to serve as your decision maker, there really are options. It can include asking a close neighbor, someone from your church or a book club, or someone that you intentionally develop a relationship with to serve in this purpose. And developing a relationship with someone may well help out that other person as well. If you decide to be each other's person, each other's medical power of attorney, as long as you have a good conversation about what each other would want. If these scenarios don't resonate for people, there are also advocates such as case managers who are willing to serve as a medical power of attorney, and it's usually for a fee. And many times people just need encouragement to think outside the box of who might be willing and able to serve in this role. So thanks so much for the opportunity, and I hope this information helps debunk some of additional common myths. And now I'd like to introduce turn it over to our next presenter.
Hi, everyone. My name is Anisha Lucero. My background is in social work, hospice, and palliative care. I'm coming to you as the Director of Family Services with Sangre de Cristo Community Care, which was formerly Sangre de Cristo Hospice and Palliative Care. Next slide, please. I wanted to take an opportunity today to really touch base on advanced directives in the context of taking a look at personal values and spirituality or religious preferences that may come up in those conversations that you'll start to have. The first point here that I had noted was, asking yourself, what do you consider quality of life? And what is most important to you? That question can help to get your mind, jogging on what your values are. Thinking about how you're going to start that conversation. Who do you want to be present, for the discussion? And are there organic ways to start the conversation, possibly through general conversation? Where would you be most comfortable speaking about your life wishes? Thinking about what you perceive or want to define as acceptable quality of life. Thinking about things such as daily function and what would be most acceptable to you. Maybe you're someone who wants to live independently at all costs, or maybe the most important thing is for you to be able to speak with and see your loved ones. It's important to start the foundation of these important discussions with not only your medical provider, but also with your trusted family members or possible medical POA. Other questions that you might consider when thinking about quality of life and in discussing your wishes or your values with your loved ones are, how comfortable do I want to be? How do I want people to treat me? And what specifics do you want your loved ones to know? Taking a look back on your own life experiences and discussing the positives and the negatives of things that you have maybe been a part of or have witnessed before in the past when seeing somebody who has, an illness or was in a life-altering situation. The next point there I have are their specifics to your religion, that you might want to discuss. Some common related questions to this and advanced directive planning is oftentimes I will hear people say that they perceive, suffering as having some sort of a spiritual value. Asking themselves, what do my spiritual or religious teachings say on how I should respond to personal challenges, to disabilities and infirmities? And, then there are those who have the contemplating thought of, by creating an advance directive, am I hindering life or am I preserving life? Is it following the natural course? You know, if these are questions that you are contemplating on, I want to encourage you at this time to speak with your local priest, pastor, chaplain, or clergy. Most persons, enjoy these conversations as people think of their clergy or religious affiliates as being medically non-biased. So sometimes their conversations can be a little bit more fluid with them. And oftentimes, our religious confidants have served on interdisciplinary teams, worked in hospital settings, worked in long-term care settings, or have even attained personal advanced directive trainings. Chances are that they may be very comfortable with having these discussions and are just waiting for the initiation of the topic to do so. That kind of brings me into the next point that says allowing control and giving yourself the autonomy to own the control through initiating and asking. When we're initiating these difficult conversations and when we're asking, it's really just giving yourself the autonomy and the control over your life and over the wishes that you want to set forth when you are unable to communicate those effectively. It empowers your family, your loved one, or your medical power of attorney to speak on your behalf. And by having these conversations, you allow flexibility and confirmation of what you wish. Initiating conversation and asking questions can positively influence grief, as your family and loved ones will know what you want. Seeking more education is good. There really is no right or wrong choices, no right or wrong questions, only what is right for you. It really is, a sensitive process. Advanced care planning is so sensitive that it can range, depending on illness or possible disease, thinking about gender, thinking about age, thinking about social and cultural context. Which is why educating ourselves, our loved ones, and our community is so very important, as it really is a very personal decision-making process. So I hope, through this brief period of encouragement that you will think about your values, think about spirituality and how maybe even some of your cultural context can feed into and provide insight for your loved ones when doing advanced care planning and creating those medical power of attorneys or those MOST forms or those other forms of advanced directives. I'd like to go ahead and pass it on to Christine, and I'll let her introduce herself.
Thank you so much, Anisha, and hello, everyone. I'm Christine LaRocca. I'm a board-certified geriatrician, and way back when, I completed my internship, residency, and fellowship at the University of Colorado. And for those medical providers that are on the phone, a big hello. Currently, I serve as one of the medical directors at Telegen. Telegen is a population health management company, and we serve as Colorado's Medicare Quality Improvement Organization, or QIO. And as your QIO, we're tasked with improving the quality of health care delivered to Medicare beneficiaries and by extension to all Coloradans. And I invite you to visit our no-cost services as you contemplate your advanced directives or other aspects of your quality of care. It's a true honor today to be on this panel with Cari, Jean, Peggy, and Anisha. So we could go to the next slide. So hopefully, at this point of the presentation, we've successfully inspired everyone to take action, whether that is to start having conversations with your loved ones or your designated person that you would trust about your end-of-life care wishes, or if you already have advanced directives in place, to act by taking a fresh look at them to see if they're still in line with what matters most to you at the current status, with the current status of your health, with COVID-19 in mind, and confirm that your choice for your proxy decision maker or medical durable power of attorney has not changed, and that this person is still willing and able. We've covered why now during this COVID-19 pandemic and what you need to know. And so the next question we want to address is a common one, and it's, how do I begin? So I would like to introduce this new guide that's specific to COVID-19 from the Conversation Project. For those who are unfamiliar, the Conversation Project is a public engagement initiative with a very simple goal: to have every person's wishes for end-of-life care expressed and respected. And the link to the website is listed here, and there you'll find a number of excellent starter kits and tools and helpful materials as you start this conversation. The new guide was created by the Conversation Project and Ariadne Labs, and it's called Being Prepared in the Time of COVID-19. It's available in English and in Spanish, and using it may help decrease that sense of overwhelm and loss of control that people may feel when thinking about advanced directive planning, especially during these difficult and frankly scary times. The guide is great, in my opinion, because it is short and it lists 3 important things each of us can do to be prepared. Number 1, pick your person. Pick your person to be your healthcare decision maker. There is links in the guide to help you choose, have that conversation, and then make it official by putting it in writing. The number 2 is talk about what matters most to you. It's good to go through scenarios, talk with your important people and your decision maker about your preferences, some of which we've gone over already in today's talk. And after you talk to your loved ones about what matters, talk to your healthcare team. This can be done over the phone now that many people are trying to stay safer at home via a televisit in the midst of this pandemic. So if we go to the next slide. Great. So the third question, and this is a very helpful part of this just 2-page simple guide, is think about what you would want if you became seriously ill with COVID-19. And there are questions in the guide and examples listed with space for you to write in your response. For instance, the first question is, what would be most important to you? And some of the examples are, as has been addressed earlier, being comfortable versus trying all possible treatments, or maybe trying all possible treatments for a specified period of time. And I've highlighted this one tool, but please note there are many, many excellent tools and resources available. And a list of some of these will be shared by email to all of you following this webinar. I've picked this one tool for our discussion today, and you should know, of course, you're free to use others, because there's a saying that I really embrace. The best tool is the one that you'll actually use. So now I think I'm turning it back over to Cari.
Yes, thank you, Christine. I appreciate you reviewing that very practical start for folks. We have wonderful questions in the Q&A, and I encourage you to continue to enter your questions in there, and we'll begin those in just a moment. I did want to go ahead and return to Mr. Cooper to go ahead and close that conversation, relying on some of the material that's just been presented. So as you may recall, or if you're a little bit late getting to the presentation, this was a gentleman, 72 years old, who was admitted and ultimately confirmed to have coronavirus. The medical team was very concerned that he may ultimately need mechanical ventilation to sustain life. And so they wanted to know his beliefs and wishes and what mattered to him most with regard to that decision. We really weren't able to get that information from him. So we had called his wife, but his wife did not have a phone with her as she was headed home from the emergency room. So his daughter felt that indeed he would want to be intubated. And this actually goes to one of the questions in the chat, which is what is the right thing to do during COVID if an older adult becomes ill enough to need ventilation. And in the past, they've thought, gosh, I wouldn't want to be on mechanical ventilation, but maybe this is different. Maybe this is a different illness and I can get through. So what we did was we tried again to talk to him. He really wasn't in a position to make medical decisions. He didn't have capacity to make medical decisions. We supported him as best we could with non-invasive breathing supports. Unfortunately, we were able to get a hold of his wife. He had not completed formal documents, and this took the better part of a night to try to speak to him, to speak to his wife, to speak to his daughter, to hear from his wife about what mattered to him. And ultimately, we were able to speak to her, his wife, about a conversation they had recently had about how he had a friend who was intubated, and that was very unacceptable to him. He said, I've never wanted to be on breathing machines. Certainly the experience with his friend confirmed that. His friend did recover, but not to the state that he found acceptable, that Mr. Cooper found acceptable. His friend was now in a nursing home. He'd become quite debilitated from his time when he was intubated, and that was really unacceptable to Mr. Cooper. He valued his ability to be independent, so much so that when he was able to make decisions on his own, he was supported with non-invasive ventilation and got to a point where he was thinking more clearly and did have capacity. And at that time he said, I would like to go home. I would much prefer to be in my home, even if that's where I ultimately die. It's where I'd rather die. I do not want to be intubated. And we arranged for him to be transferred home in pretty short order. So that's the conclusion to his case. And I don't know if others want to comment on the wisdom or the peril of being intubated during COVID. My experience, and from what I have read early on, the data looked very dismal for older adults who were intubated and the outcomes. We've certainly had a number of patients who have been intubated, they have been extubated, they've been extremely long courses of illness. They've ended up very much like Mr. Cooper's friend, where they've had a lot of debility associated with that intubation. Others have had shorter times of intubation and have been extubated successfully and gone home. So it's a very difficult thing to say definitively how the outcome will look. And that's why we go back to these conversations about what matters and why these documents are so helpful to work through. So I don't know that I have a crystal clear answer. I wish that I did. We certainly have more and more literature every day. We're all still working through, who's at most risk and who's at the least risk of bad outcomes related to COVID. But what I did want to do was summarize what we have talked about. We might come back to this one more time after we go through the Q&A. But what you heard loud and clear from all the presenters is so critical to have someone to make decisions, someone that's legally appointed to make medical decisions for you if you're incapacitated, as we saw in Mr. Cooper's case, and a good conversation to support that. The directive to be my medical decision maker without any context about what matters is really a difficult place to put someone in. So those conversations also need to happen. And as Dr. LaRocca presented, we have lots of tools to help through those conversations. The second is to not stop there and to allow it to be an ongoing conversation because of things like COVID. Times change, healthcare changes, health changes. And so this can't be a one-stop conversation or a one-time conversation. It really does need to be something we do more often. The other thing that we encourage folks to do is, if you've articulated your advanced care plan, help others understand how important that is. Certainly this case of Mr. Cooper emphasized to all of us how difficult it is when we don't know what people want. It was very hard on his wife, it was very hard on his daughter, and there was a lot of disagreement between them. It took, as I say, the entire night of this medical team to sort things out. And when we see people come in who've clearly had those documents in place, things are just so much more smooth. The care can be provided in a much smoother fashion. And then finally, make sure it's available. So sometimes people have gone to all the trouble of articulating their plan and then we can't find it. So if there are places that you may be, whether it's a hospital or a doctor's office, or make sure that family who will be contacted if you do become ill have that advanced directive available. So with that, I want to go ahead and begin the question and answer period, and I hope our panelists will go ahead and chime in as you would like as we read these questions. The first one Jean already commented on. The first one was, well, what is sudden? We talk about sudden death, and the question was, if someone has an unexpected condition that takes their life within a month, would that be considered a sudden death? And what we're talking about in a sudden death often is the sudden cardiac death that occurs, and death occurs instantly or relatively instantly, or something within a week or so of the onset of illness to the time of death. Did anybody else want to comment on sudden death?
Not particularly, but I like circling back, Cari, to your case of Mr. Cooper and some of the other questions about what are the unintended consequences of making the choice. If you hadn't been able to get a hold of Mr. Cooper's family and he hadn't cleared up enough, and you had been forced, your hand had been forced either to have him die or to intubate him, it's not the end of the world to have intubated somebody. We spend a lot of time in ethics talking about the difference between withholding treatments, particularly from my perspective in the emergency department, and withdrawing treatments that turn out to either not be working well or not be wanted when the dust settles and we gather those advance directives and we have a chance to talk to the family. That's perfectly acceptable, even though it feels worse to have to withdraw something. Sometimes that's the best thing to do because it allows us to calm down, cool the temperature in the room, and sort out what's really in what somebody would really want.
Thank you for adding that, Jean. And that's what we would have done, of course, would be to intubate him. Fortunately, we did have some clarity before it came to that. The next question is, does legislation around living wills and advance directives vary by state? And Jean, you've just been on it. You answered this one as well. So yes, they do vary quite a bit by state. Our state has an unusual one, and we will have links for that in the documents that we send you after the presentation today. And so it does vary. So that's important to be aware of. Did anyone else want to comment on this particular question?
I would just say one of the nuances in Colorado is that the medical power of attorney advance directive does not require a witness or notary, but some states it does. And so just for kind of people to be aware of that, I think that's a helpful kind of nuance of the differences. But I think states tend to do their best to honor other states' directives when a person comes to Colorado. We still look at it and give it a lot of credence. And that's just my comment.
And one of the other myths we should probably add to our list is, oh, my spouse will be the one who makes decisions for me, because as Cari was saying, and Peggy also, in Colorado, nobody has this precedence over making decisions. And that surprises a lot of people as their loved one rolls into the ER.
Yeah, and even when we do have more clarity, so this happened to be a veteran, he was in the VA, and we do have a hierarchy of decision making, but we're obviously not going to omit the important family dynamic that's there, or ignore the family dynamic. So we did have a lot of work to do in the middle of the night with this family, even though we do have a hierarchy, and we would have accepted his wife's decision. So it's complex.
I did want to add, Cari, to that, and for what I'm hearing is that the instant thought that it would be your spouse, and again, Jean clarified that that's not the case, is that you really want to pick a decision maker, proxy, medical durable power of attorney, who you feel would be able to speak on your behalf. And sometimes, for instance, I wouldn't pick my young son to speak on my behalf because fortunately he just loves me a lot, and he would probably say, no, do everything just to save her, whether those were my wishes or not. The person should be able to speak on your behalf.
Thanks for that, Christine. Excellent. The next question is about PTSD outcomes. After ventilation from COVID treatment, how about the end of life requests, I think, again, related to COVID treatment? Does anyone want to comment on that? This has been a particularly difficult time where visitors are not allowed, and a lot of these decisions are being made either over the phone or via video chat. Any of the speakers want to take that one on?
I'll take a little bit of a crack at it, which is just to criticize the fact that when we're in the beginning of this brand new epidemic, we are good at counting deaths, but we are not good at assessing the morbidity, what we would call, which includes the stress, which is to families and healthcare workers are experiencing a lot of stress, as well as to patients, plus the physical issues like debility that is going to require recovery afterwards. We don't know how many people get back to the kind of quality of life that they would find acceptable. These are things that take a lot of long, hard studying before we're going to understand and get it, which makes it really hard to balance the burdens and the benefits of choosing treatment, as you or I would have to be facing treatments if we got sick.
I definitely think there's going to be a lot of research coming out here within the near future after we've seen the results of the COVID-19 and just what that means for mental health in general. I think that our community and even our nation as a whole is starting to take a look at mental health and how some of these factors are going to play into all of that, for sure.
Absolutely.
And I would just add one more comment to support what Jean and Anisha said as well. Is one caveat is I've noticed in healthcare in the years that I've done it is that the more robust conversations are around end of life and around normalizing that we all need to be talking about this, it seems like the PTSD in those families is much less, because they've had a chance to prepare and know what some of the, what that person would or would not have wanted. And that can really help alleviate some of the occurrences of PTSD.
I know several of the families we've had to call regularly with updates because, of course, they haven't been allowed in the hospital. They will answer the phone very nervously. And the first thing we learned to say was, I'm calling with a non-urgent update, because they would assume that things were going badly every time they got a call from the hospital. So we made a few adjustments to help the families know it was us and that it was not urgent. And that was hopefully a little bit of a relief to them. But certainly the experience of being there, we've had a couple of ceremonies where families have been available outside the hospital when their loved one's being discharged after a prolonged ICU stay. And it's very shocking, really, because we've been seeing these patients day after day after day, and then you see the families there who haven't seen them in months, and they embrace and they cry, and you just are shocked by that experience, because it's so discordant with what we're used to in healthcare, and of course what we encourage people to be available and with their loved ones. So I think there's no question we'll learn a lot about this. I think we don't know a lot now. So thank you for that question. The next is, I'm beginning initiatives to train long-term care employees to initiate advanced care planning discussions among their residents. Has anyone done something similar in their organization? Are there any pointers? And all feedback would be much appreciated. There are some wonderful videos by Volandes that can be used in the long-term care setting. We can certainly send those out with the resources. There's a number of resources. And if this individual in particular wants to email cari.levy@va.gov, it's just, it'll be in the slides. Please do, and I can send you some more resources. Did others want to comment? Christine, did you want to comment specifically on those resources?
Well, the ones from the Colorado Department of Public Health and Environment are particularly good as well. No shortage of resources out there, and maybe if you scanned them and looked at which ones might feel most comfortable for you to use. And several of them are available in different languages. Jean, I thought you were nodding your head about to say something, so I'll turn it over to you.
Well, no, Peggy and I have been working on this, Peggy particularly on outreach to long-term care facilities, but in the resources that we send you tomorrow or Monday, we'll have some links to the CAPC, C-A-P-C, Vital Talk, the Conversation Project, lots of different links that have fun videos and videos that help you practice the kinds of conversations. There's some wonderful stuff, as you say, Christine, out there.
Yeah. Bottom line is don't make this hard for yourself. There's lots of resources and they're very good.
Yeah.
Yeah, and
I will add the one, oh, sorry, Peggy.
No, go ahead. You can go.
Peggy, go ahead.
Okay, I'll
Okay.
say what
Yeah.
I was going to say.
Okay.
In working in long-term care for the 10 years that I did, I think one of the most important, the most important document is the medical durable power of attorney, and ensuring that that person has a conversation around that. And one of the most high quality resources is the Conversation Project. Another document that often gets completed in skilled nursing, because it's oftentimes those people are more seriously ill, is the document that is actually not an advanced directive, but it's a most form because they're medical orders. And I would encourage, because a lot of long-term care facilities do use this document, that you ensure that the people that are helping fill out that document really do have the training and understanding, and that they work closely with the medical provider. And there's a lot of good information on the Civic website around that, and again in the resources, and I'm happy to be a resource as well. My email is peggy.budai@uchealth.org. So that's a great question, so thank you.
Thank you.
I was just going to, I was just going to add that for some nursing home residents, they believe that if they have all of their advanced directives in place, that means that there may be an assumption that means that they wouldn't go to the hospital during COVID-19. So you may want to specifically ask them if hospitalization is within their wishes during this time.
Thank you. Thank you for that, Christine. Yes, so often if you're leaving an environment where staff know you feel comfortable, it's your home, to go to a hospital where staff won't know you, your family can't even be with you, and there's no visitors. It really is an unbelievably difficult decision to make, and one that a lot of our long-term care residents have had to make in recent months. The next question, and I will have to have someone cut me off because we have many questions. It's very exciting. And we might go through them as a speaker group and do our best to answer them and include that in the materials that we send out afterwards. The next one is, what is being done about family, friend, and medical power of attorney being with a COVID patient who is critically ill? My experience is that they aren't allowed to be in the hospital. And so we've done a lot with visits via video. So we've certainly had iPads available to individuals. And then just recently, we've developed a visitor policy so that the individual can have a visitor if it's clear it's an end-of-life situation. And that visitor then has a number of agreements that they make with us about protecting themselves and others after they've been exposed to that individual. But can others comment on how you all have handled being with someone who's critically ill with COVID?
Being in hospice, I can speak to, down here in Southern Colorado, we've really seen a variety of everything on the spectrum. Some people are allowing just one family member at bedside. Some people are allowing nobody to even, come and be at bedside, which is terribly sad. I think because this is such a new concept for all of our communities, that everybody is just trying to kind of fill out what would be the best. And it's just been my experience that everybody is doing something a little bit different. So it's kind of hard to say what the norm is or what the norm will look like. But I definitely think that people are experimenting with what can be the best and in the best interest of those who are, terminally ill and passing.
Yeah, I think we're all trying to figure this out to get for that, Anisha. So we are at the top of the hour and need to respect time. So if there are any final comments from our speakers, did you want to say any final words before we close?
I would just say, if you haven't completed your advanced directive, picked a person and made it legal on a medical power of attorney to do that, and have that be a gift to your family and to talk to them about your preferences.
It's hard to have these conversations, but it's a little easier in these days of COVID. That may be a silver lining. And it's a gift to your family to start them talking about your wishes, but also to give them a little bit of practice so that they start to talk about their own wishes, even if they're younger, because everybody should get a little more comfortable talking about the fact that we are mortal creatures and we all will die.
Thank you, Jean. Anisha, did you have any final comments?
Just, I second what Jean and Peggy have already said. I think it's super important to, start initiating these conversations and to really, take a look at what your advance directive is, even if it's just getting that medical power of attorney on paper.
Thank you all so much. It looks like Christine may have dropped off, so I'm sorry she's not able to make final comments.
I'm on, Cari. Yeah, but it's okay. I just, if you have an advance directive, it allows those caring for you to respect you. And for me, that's my parting thought. We want to respect your wishes, but if we don't know what they are, makes it difficult to do.
Great. Thank you so much, Christine. And as mentioned, we will be sending out a number of documents following this presentation in the next day or two. So please look for those. And we are so pleased to have you here today. Thank you very much, and take good care.